Good morning, good afternoon, and possibly good evening to some. My name is Julia Martin, and I am the Head of Strategy and Policy at the Global Fund Secretariat. I'm pleased to be with you today. I'm going to start us off on the GC allocations and then quickly pass to colleagues who will walk you through some of the specifics. Next slide, please. So just to provide a little bit of context to the allocation formula and the resulting country allocations, we'd like to be as forthcoming as possible to describe what is a very robust process led by board policies and by Global Fund board policies, and eventually shows up in allocation letters that you have all received most recently. So the first thing I would like to start with is to reinforce that GC8 has two main points of focus, and that is sustainable programs and effective transitions. And they apply to all countries that are with the support of the Global Fund. Sometimes the transition more specific to others, some countries than others. Within that, those two main aims, there are a series of what the Secretariat is called GC8 strategic shifts. And if you joined a session on the GC8 shifts last week, you would have heard a lot of detail around the 6 shifts. We'll not be going into the shifts, but why I start there is one of the shifts is to ensure that as much funding as is safe and wise can be moved to countries with the highest disease burden and the lowest economic capacity. This was a board directive, a board decision, that we take the allocation formula, we make some adaptations to it to ensure in a time where funding for global public health has reduced overall, that countries with the highest burden and the least ability to cover the financial burden of those diseases are prioritized. That does not mean exclusively, and we'll get to that. If you're not aware, here's a number that for country allocations, there's 10.7 billion that has been allocated for country allocations in GC8. This comes after an exceedingly positive GC8 replenishment or 8th replenishment. And the reason I say that is not because it was as high as GC7 and the 7th replenishment, but because in our context, we are grateful for the donors, private sector, private foundation, and public donors that have made such a robust 8th replenishment outcome. We're also appreciative in advance of country governments who have already increased their spending on health and on the 3 diseases and look for more of that to continue. So based on the current cycle of GC8, we are just about 20% less than the GC7 country allocations at the starting point. However, you are all very well aware that mid-cycle in GC7 last May to June and through to September, there was a reduction in funds available for countries in the GC7 round because of fluctuations in donor financing. So from that point, when there were reductions in GC7 to GC8 of 10.7 billion, it's a 7.6% reduction. So not as steep as the near 18%. That 18% could look daunting, but a lot of work has already been done by countries, by partners, to help reduce the programmatic costs and footprint in countries. The thing that is important is that almost every country has had a reduced allocation, as just communicated through the allocation letters. However, the low income and challenging operating environment allocations received the most limited reductions, as per the first bullet, where the prioritization has landed. So I think the other thing that's important to say is how we've made that shift to prioritizing high burden, low economic capacity, and that's through policies. The board had 2 significant policy shifts or adaptations for this cycle. And one was that we adapted the formula that resulted in the allocations in a way that shifts more funds to the lower income countries. So there was an actual change in the methodology. So it's very quantitative. It is not qualitative in that aspect. The second piece, and Yun will follow me, will speak more to both of these points. The second is that in doing that shift, there was a benefit to low income countries with high disease burdens in HIV and TB. The same was not true of malaria. The reason is funding in this shift largely came from upper middle income countries and those that have TB and HIV burdens, but there are not upper middle income countries with significant malaria burden. And so financing for malaria was not moved and adjusted in the same way. The board then took a decision to provide the Secretariat with flexibility to enhance the malaria allocations in low income countries and high burden up to a certain threshold. The last thing I'm going to say is that with all of this, with less money overall, with shifts to high burden countries, increasingly, with transitions in a number of countries where the GC8 cycle will be the final allocation, it is incredibly important that as a collective, we prioritize. Rigorous prioritization that is based on a country's current epidemiological status, even at the subnational level, with rigorous prioritization of program interventions, including how and what things should be dropped and stopped in order to create space for new innovations like lenacapavir and TB diagnostics and to increase the coverage of next-gen malaria nets. And so, and with all in this mix, keeping a very keen eye on creating sustainable space for community systems. And the vulnerability of the financing for those systems increases with less money. So a call out to that specific area. So keeping this in mind, I'm going to pass to Yun, who will walk through the allocation methodology and the decisions and the outcomes made. Thank you.
Thanks, Julia. If you could go to the next slide, please. So what you see in front of you is the board-approved allocation methodology for this cycle. Just if you start on the left side with that first gray bar, that represents the total available funding for allocations after the replenishment, once that amount is known. When that amount is known, the first thing we do is to deduct the catalytic investments, and the remaining amount goes to country allocations. The 10.783 billion is run through an allocation formula. So the first step in the allocation formula, and that's all of the graphics under that sort of green area in the middle, that's the allocation formula. The first step there is to split the total funding into the three diseases for HIV, TB, and malaria. Everything that happens after that is within the disease pot of funding. So the formula will, let's take HIV allocations, for example, will calculate for an eligible country a funding share that is based on its HIV burden and on its economic capacity. Those are the main driving parameters of the formula. Then you see after that in those gray and green bars, another step in the formula, and that's what we call the scale up and paste reduction step. The aim there is to address the predictability of funding as we move from a previous cycle to the current one. So once the formula produces the allocation amounts, each of those amounts are reviewed country by country by the qualitative adjustment process. It's a process that is overseen by the strategy committee, and they approve all of the factors that we consider there. These are country-specific factors that could not be captured or fully captured in the formula. For example, for HIV, we adjust for the specific populations that are disproportionately affected by HIV within country. There are coverage gaps, RSSH, fiscal space. A lot of factors are considered there holistically at the country level. And where it makes sense, incremental adjustments are made to that formula amount. So that's how we get to these final allocations. There were two important changes for this cycle. One, which Julia already mentioned, was the country economic capacity curve. So that's, the part in the formula that is represented by GNI per capita. That curve was updated in order to shift more funds from higher income countries to lower income countries. The second key change this cycle was in the malaria burden indicators, and that's where the WHO had recommended that we account for countries where there has been a recent rising incidence. So if you could go to the next slide, please. What you see in front of you is then the resulting split of the allocation formula and the incremental adjustments that were taken in the qualitative adjustment process. Maybe just to go over what this chart is showing you, starting on the left side, the first bar is the allocations in grant cycle 6. The second one is grant cycle 7 at the beginning of that cycle back in December 2022. The third one is after the reprioritization that everyone has gone through last year, so the reduced grant cycle 7 amount, and the last one is grant cycle 8. So the resulting split by disease then for grant cycle 8 is 5.278 billion for HIV, 1.964 billion for TB, and 3.54 billion for malaria. Next slide, please. So if we look at the GC8 allocations by income group, every income group in absolute funding amounts is coming down. That funding is decreasing. However, based on the strategic shifts that Julia had mentioned, the share of the total funding for the lowest income countries is increasing. So that's from 40.2% in GC7 to 42.6% in this cycle. And then the blue section, those represent the lower middle income countries. Their funding shares are relatively stable at approximately 44% in both the previous cycle and the current one. Next slide, please. What this shows you, so you find the same sort of pattern if we also look at it from the perspective of where there is the highest burden across HIV, TB, and malaria. The darker coloring on the bottom of these charts represent the allocation amounts in each of these cycles for countries that are in top 15 burden for that disease and are also low income or lower middle income. So as you can see for all three diseases, that funding share from the previous cycle to this one is increasing slightly. So for HIV, that means that group of countries, their allocations are going from 54% to 56%. For TB, it's 28% to 31%, and for malaria, 60 to 62%. And the lighter coloring on those bars represent the rest of the portfolio. Next slide, please. And then finally, these are the allocations by the Global Fund Board constituency regions. Every region in absolute amounts, again, the funding is coming down, but there is a slight further concentration of the funds in the Africa continent. And as of this cycle, their allocations represent 79% of the total funding. And in general, I'll just say that, the numbers that you see here are representative of the varying income levels and different burden of disease like within those regions. So that's really it from us. And we're happy to take your questions, but first let me turn over to Lily on Catalytic.
Great, thank you so much, Yoon. My name's Lily, and I manage our Catalytic investments along with many other people at the Secretariat. So we can go to the next slide, please. So Catalytic investments are meant to work alongside country allocations, and they direct funding to critical needs that country allocations can't resolve on their own. These are areas that we identified through an iterative process and that were approved by the Global Fund Board and they often focus on cross-cutting priorities. So things like global activities to increase access to the most effective and innovative health products. CIs are operationalized through 3 different modalities or types of investments. And the one that we'll focus on the most today is matching funds, because they're approved the earliest in the cycle, and eligibility for matching funds is included in allocation letters. Matching funds represent additive funding, so additional to the country allocation, and they're available to selected countries to incentivize focus on key strategic areas that have been approved by the Global Fund Board as really critical. As the name implies, the available matching fund amount must be matched with an investment from the country allocation, and the details about that matching amount are included in the country allocation letter. When awarded, matching funds are integrated directly into country grants, and they're deployed alongside grant funds at the country level. The next modality is strategic initiatives, and these are centrally managed investments that can't be operationalized through grants because they're innovative and really focused on piloting, or because they're cross-cutting and off-cycle. Strategic initiatives are just in the beginning of their design phase now, and they'll be approved over the course of 2026 and start in 2027. So countries will begin to interact more with strategic initiatives later in the process. The last investment type within Catalytic investments are multi-country grants. And these are a limited set of investments that target predefined regional priorities that require coordinated action across multiple countries. They're approved on differentiated timelines, really depending on the needs in the specific region. Next slide, please. So the Catalytic investments are approved by the Global Fund Board at an overarching priority level. And the priorities for GC8 you can see listed at the top of this slide. These priorities were identified and refined with feedback from partners and constituents to focus on our most critical collective challenges and the ones that we can't address through grants alone. So there's really strong alignment between the strategic shifts that Julia spoke about at the beginning and where these priorities direct support in GC8. The grants are our strongest engine to operationalize those strategic shifts, to support transition and focus resources on the highest burden, lowest income settings. But Catalytic investments can reinforce that through targeted support. I also want to mention that there's one additional specialized priority that's not shown here, which is the emergency fund, and it directs resources to sustain HTM services during crises. So it acts really agilely and adaptively across many of the shifts in the areas you see here. Next slide, please. So in February, the Global Fund Board not only approved those GC8 Catalytic investment priorities, but they also approved an amount associated with each priority. And this funding comes partially from the sources of funds available for allocation. So the little gray bar that Yoon showed in an earlier slide. And then a significant share comes from additive contributions from private sector donors. The table on this slide shows what was approved by the board. So it includes the overarching priority and then the components that make up each of those priorities. And then the individual matching funds that I'll talk about next, along with the strategic initiatives and multi-country grants, are even one level lower. So they're the investments that together make up the components that you see here. Next slide, please. So to zoom in on matching funds, the overall Catalytic funding is limited. So matching funds are available just to a selected set of countries. Countries are prioritized to align with the objectives of those individual matching funds. So for example, a matching fund focused on expanding social contracting to ensure sustainable access to services would prioritize countries where social contracting is a national priority. Eligibility for specified matching funds is included in the country allocation letter, and the letter also lists the relevant matching fund amounts available, so the total award that a country could receive for each matching fund. To access matching funds, the countries would need to meet certain financial and programmatic conditions. So financial conditions outline the minimum country allocation investment required within each priority area. For example, a matching fund that requires a one-to-one match, meaning that to access the available matching funds, the country would need to commit to invest at least the same amount from their country allocation in that priority area. Programmatic conditions are equally important, and they describe the programmatic elements that need to be reflected in the applicant's GC8 funding application. They usually capture any other critical elements about how funds should be invested, and any prerequisites that are really important to have in place. The allocation letters include a link to this full list of financial and programmatic conditions for each matching fund. And in addition, the Secretariat is also preparing matching fund guidance that will aim to answer common questions and support countries in planning and investing matching funds. These conditions are ultimately verified as part of the funding application and grant-making process. And when conditions are met, matching funds are integrated into the relevant grant. Next slide, please. So in GC8, there are 6 matching funds, and they cut across 3 of those different priorities that you saw earlier. There's diversity in the funding available for each matching fund, and as a result, how many countries each matching fund can serve. So I'll just very briefly walk through the high-level objectives of those 6 matching funds. For the matching fund on community and health services for women and children, the matching fund aims to strengthen integrated health services for women and children, recognizing that this is a really critical opportunity to advance integration and to increase maturity and sustainability of health workforce and community health worker systems. The matching fund to expand social contracting to enable access to services seeks to catalyze social contracting so that community-led and community-based organizations can deliver HIV, TB, and malaria services for key and vulnerable populations, and use domestic resources to move toward long-term institutionalization of these mechanisms. The Integrated HIV Prevention Matching Fund aims to expand coverage of HIV self-testing and diversify self-testing kits, to broaden access to PrEP, capitalizing on lenacapavir investments, and to support integration of HIV prevention services to improve health outcomes and system efficiency. The Matching Fund on Digital Solutions supporting integration seeks to strengthen national digital health systems in use based on countries' individual strategies and structures, all to improve services and increase efficiency of integrated primary healthcare programs. The Matching Fund on Public Financial Management aims to enhance financial governance and accountability to enable financial sustainability and strengthen country ownership. And finally, the Matching Fund to address human rights and gender barriers to services seeks to catalyze national ownership of programs to remove barriers to HIV, TB, and malaria services, specifically those that are human rights and gender related. And this supports targeted programmatic interventions to address those barriers and sustain access to essential and quality HIV, TB, and malaria services. So these matching funds are diverse. They cover a number of different areas, but what's common across them is they can create space for innovation and to have greater, more catalytic impact in important priority areas. And in some cases, they can help by providing additive resources that help to maintain essential services and access for the people who need it the most. So I'll stop there and hand over to Marcella for questions.
Okay, actually, Marcella, can I come in?
Thanks. Yes, yes, Julia, please.
No, go ahead. I just didn't see you on, but please, lead us into the Q&A. Thank you.
Sorry, no, I'm here. We were going to go to the next slide. Alex, if you can put the first set of questions. For the participants, I'm going to read the questions so that interpreters can share it in different languages. Can countries procure lenacapavir as part of the integrated HIV prevention matching fund? Second question is, the qualitative adjustments are noted as being transparent and accountable, but it does not seem to be possible to see what those qualitative adjustments were, how they were decided, or what the financial impact was. Are there plans to release this information for each country and component? Next question is, with the recent shift into grant cycle aid, how does a formal deferral of low development countries, right? least developed countries, graduation impact the sustainability transition and co-financing requirements? Does a deferral automatically freeze the accelerated transition timelines, or are allocations for already approved components subject to revision based on the original 2026 graduation target? What does external financing and maximum minimum shares means? And what is the global disease split and final allocation proportion between HIV, TB, and malaria? So we're going to go to the first question, and I think that's for Lily.
Mhm.
Yes, so for the Integrated HIV Prevention Matching Fund, the catalytic investment money, the matching fund funds, and the associated match from the country allocation can be invested in procurement of HIV self-testing and PrEP service delivery and commodities. And the idea is that there would be a mix that's appropriate to that country. So it would be agreed during the funding request development. So LEN would be applicable, but as part of a broader discussion and package that makes sense for that country.
Thank you. And Marcella,
Yes.
I'm going to take number 2. And thank you for the question on the transparency and accountability. First off, all countries go through a discussion of qualitative adjustment. All countries do not see an adjustment made. There are some countries that the allocation formula, the outcome is the outcome. So just to keep in mind that piece. The second is that the strategy committee, which is a subcommittee of the board, and the board itself receive a qualitative adjustment report, which does provide the details by country, by component where the adjustments were made. These are not papers or documents that are restricted in terms of the access to the board. The board constituencies are many and large. And so there are many, there is an ability to see that information. And so what I would say is, do we post it so anyone can utilize it? No, because it is a board level direction, but we are completely transparent about the metrics that are used and the outcomes that are done. The metrics are by which qualitative adjustments are done, as well as the overall disease burden metrics in the allocation formula, are directed and guided by the partners, the technical partners, UNAIDS, WHO, Stop TB, the Malaria Partnership. And so they're very much informed by our technical partners as well. So it is a group effort, and there's transparency in that as well. And I'm going to pass on now to Matt, followed by Gideon.
Thanks very much, Julia. So on question 3, I'm not sure if I understand it perfectly. So maybe just I'll provide 2 quick comments. We do have a number of countries who are transitioning away from Global Fund support in GC8 and GC9. And we've provided that information to countries in allocation letters. And that's really done to try to enhance the predictability of the financing and work with countries in a gradual manner to transition away. If there was a transition that was already happening before grant cycle 8, that doesn't change. The countries that have transition timelines in GC8 and GC9 moving forward will continue. I'm not sure if that was the question. The question might be about the fact that countries change across income cycles, income levels. And some countries who are expected to move across income levels don't always move as they were expected. The way that the Global Fund works on this is that we use, for the purposes of our SDC policy requirements, for the purposes of co-financing requirements, whichever income level a country is in at the time of the start of the allocation is the income level that they're in for the implementation period. And that's so that we don't have to change midstream our requirements and our metrics. That said, we always work under a situation of flexibility. There are some places where there are very challenging circumstances in countries and income levels change, particularly in places where an income level would go down or would reduce. We often work with countries directly to see how that will affect the size or the scale of co-financing requirements. I think that probably answers the question. If I haven't, please, whoever wrote that, feel free to put it in and I will do my best to answer it later.
Thank you, Matisse. Gideon now.
Hi, I'm Gideon. I'm a specialist in the allocation team. To Ali Reza's question on what the external financing and max-min shares that we saw in that slide mean. There's an external financing step within the allocation formula, and this uses the latest available information about other donor financing. And using that, we adjust allocations to ensure that we're driving overall external funding, that's Global Fund and others, to the highest burden and lowest income countries. The minimum and the maximum shares, also part of the allocation model, put upper and lower bounds on the allocation amounts. So the minimum shares exist to ensure that all allocations for countries, no matter how small, receive allocations that are sufficient to effectively run disease programs. On the maximum shares, these exist to ensure that the Global Fund funding is not overly concentrated in a very small number of very large countries. Those maximum shares are 10% of total disease funding is the maximum that can be in any one country, and 7.5% of the Global Fund's total funding in any one country. For question 4, what is the global disease split and the final split between the 3 diseases? The allocation model disease split that was used was the board-approved global disease split, which was 49.6% for HIV, 18.6% for TB, and 31.8% for malaria. But as noted by Julia and Jörn, the board granted a limited flexibility to move funding towards malaria. And so the final split of the allocations, as we saw in the slide, will be 49% for HIV, 32.8% for malaria, and 18.2% for tuberculosis.
Okay, thanks. Gideon, if we go to the next slide, and I'm going to read this set of questions. So is the exact mathematical formula available anywhere? Although the high-level concepts, principles, and chefs are available from the November 2024 52nd board meeting notes, the exact mathematical formula was not included in a way that could be replicated. Can we apply directly from non-governmental organizations? With regards to the allocations, a bit like you have amended and protected for malaria, what are the protections in place to ring-fence funding for CSOs, CBOs, and CLOs, independently from money going to ministers of health? Crucially, money for people criminalized, not always protected, recognized, and prioritized by ministers of health, and fundamentally dependent on the Global Fund to ensure their work, response, and needs are recognized, included in the response. They're also small in the catalytic investments amounts, comparatively speaking, with funding of catalytic investments supported by private donors. And the last question on this slide, can you confirm what is the exchange rate, euros, US dollars, used to convert the US calculated allocation to euros? Euros denominated allocation seems to be reduced more in percentage than the US denominated allocations, which may be due to the GC8 exchange rate use versus the GC7-1. So for question 6, then Gideon, I'll pass back on to you, please.
So on the exact mathematical formula question, The board documents, as noted in the question from November 24, do show the detailed definitions of the disease burden metrics and the economic capacity curve. However, the formula itself is not entirely replicable because some of the input data that is used is not from public sources, notably where there are gaps in data for certain countries.
Okay, thanks, Gideon. Lindsay, can I pass you on to question 7?
Yes. Hi, my name is Lindsay Smith. I'm one of the managers in the Access to Funding department. So question 7 asks whether or not it's possible to, for a non-governmental organization to apply directly to the Global Fund for financing. The answer to this question is that the Global Fund most often works directly with country coordinating mechanisms, which we refer to as CCMs, to have the oversight over applying for funding, submitting the funding application to the Global Fund, as well as that oversight of the subsequent Global Fund grants. One of the responsibilities of the country coordinating mechanism that is assessed at the time of the funding request submission is not only to ensure that there has been inclusive country dialogue, but also to transparently use their process to nominate principal recipients with whom the Global Fund would then finalize the grant negotiations and sign the grant agreements. So an NGO could be nominated by the CCM to be a principal recipient, or could become one of the sub-recipients below that principal recipient in the implementation arrangements. But we do put the confidence in the CCM to manage this process according to their own criteria that is often documented in the CCM guidelines for each country.
Thank you, Lindsay. So for question 8, Anna, would you like to come in? Anna, we can't hear you if you're in the room. Yeah, thank you.
Sorry, I'll start again. Thank you for this really critical question regarding civil society, particularly in contexts where people are criminalized and settings. And we know as the Global Fund, it's often this is the only funding that reaches them. And in these contexts, we carry a particular responsibility to continue the work. And so the Global Fund's approach in GC8 continues to place community organizations and communities at the center of both our design and implementation. And through the CCM process, community and civil society representatives are required to meaningfully participate in country dialogue and application. There's a community annex mandatory for all high impact and core portfolios, which captures community priorities independently, ensuring they inform the review process here at the Secretariat and with the TRP, even if they're not fully reflected in the final funding request. And in implementation, our modular framework and our interventions encourage principal recipients to engage and use community-led organization for key programmatic areas, particularly, for example, with HIV prevention for key populations, community-based treatment and community system strengthening. And we'd also point out that the broader normative framework that should anchor these decisions. So for example, the UNAIDS targets around 30% of HIV service delivery should be community-led, and at least half of prevention programming for key populations should be delivered by and through community organizations. And they're benchmarks that we'd like to see and continue to support. And as part of transition planning, this is exactly the time that we need to be really conscious of this and treat it as a signal of where we need to be more explicit about working with government and with countries in continuing to engage communities and community-led organizations as a critical infrastructure in serving key populations.
Thank you, Anna. Gideon, can I ask you to respond to question 9, please?
Absolutely.
You need to, yes, thank you.
So in terms of the exact exchange rate, I don't have it to hand, but we will come back on that, the exact number. But it is absolutely the case as the questioner has observed, that the US dollar has depreciated against the euro since the previous cycle. And as a result, allocations in euros are lower. The entire allocation process is done in US dollars. And there are 4 exchanges, both between the donors who pledge in the currency of their choice and the Global Fund Secretariat, and between the Global Fund Secretariat and the recipients. This is true for the euro-denominated grants, but it's also true between US dollars and local country currency. The allocation process itself does not account for these fluctuations within allocations. But we recognize that it can absolutely create challenges in country. The change that we've seen in Forex from Grant Cycle 7 to Grant Cycle 8 is within the usual bounds that we have seen between previous cycles. It's also worth noting that just under half of budgets in previous cycles have been on commodities, which are broadly priced in US dollars. So the fact that allocations are set in US dollars is connected more directly with those commodity prices, which comprise a large portion of the grant budgets.
Okay, thanks, Gideon. We are going to the next slide, please. So is there public access on the website on which countries are eligible for which matching funds, and are the allocation letters online? I was not able to see them. Is it possible to get a percentage on the number of countries in Africa that did not get GC8 allocation letters? Is it safe to say that the Global Fund is transitioning in these countries? Another question on multi-country grants. I appreciate no confirmation of this until later, but with regards to transition, will these continue or likely be transitioned out? Can you please give the link where we can find countries eligible for matching funds? And I understand there is more focus on us to use WAMBO as the procurement agent. Is there still the option for national third-party procurement? So for question 10, Lily, can I pass on to you?
Sure. So the allocation letters are not on our website, but I think the point here is correct that the allocation letters are the first place countries should go to their individual allocation letters to understand matching fund eligibility. In previous cycles, we have published matching funds by country online, and it's our intent to do so again this cycle.
Thank you, Lily.
I think that also answers question 13.
13, okay. Thanks, Lily. Matt, can I pass on to you for 11?
Sure. I don't have a percentage on the number of countries in Africa that did not get GC8 allocation letters. What I could say is 2 things. In all of the allocation letters that we shared with countries, we were very clear and explicit about whether or not that country had a transition timeline. So for the transition timelines in GC8, GC9, we've communicated that information directly to countries. And we did that before communicating it anywhere else because we really wanted to make sure we had that conversation first directly with countries. So all of that information around those transitions is in those allocation letters. I will defer a little bit to Julia here, but if a country did not receive a Global Fund allocation letter, then we are not active. We are not currently funding in a direct country with a direct country allocation. I think I'll just hold there.
Thank you, Matt. Lily, we didn't do 12, right? We did 13.
Right. So first I should provide a clarification that there are multi-country grants that are funded from the allocation, and then there's a smaller set of multi-country grants that are funded in full or partially by Catalytic investments. And that's been the case for multiple grant cycles. So for the Catalytic investments, we spoke earlier that they're really meant to do things that we can't do through the grants. And I think there was even a stronger push going into GC8 to ensure that wherever we could structure HIV, TB, and malaria interventions, we were doing so through the country allocations. And we were using the smaller catalytic investments to do things that we couldn't do really effectively through grants. And so as a result, multi-country grants funded through catalytic investments remains small in GC8. We do still have priorities approved that are planned to be operationalized as catalytic multi-country grants in GC8. But again, that's simply because we haven't been able to fully transition that into grants. That remains the long-term intent.
And maybe if I just complement Lily to support the rest of the answer, there are also some multi-country grants that are pooled allocations together. And for those countries, we have communicated again in allocation letters about transition timelines whenever that is relevant. There are some multi-country grants that are from pooled allocations that do have transition timelines for GC8 and GC9, and we've communicated those in the allocation letters.
Okay, thanks, Matt. For 14, don't know if we have anyone from supply operations online, but otherwise, Julia, maybe you can respond to this.
Yeah, I checked. I did not see anyone. So I'll offer up perhaps a part answer. And that is correct for question 4. There is an increased focus on WAMBO because it is a pool procurement mechanism which has qualified suppliers, quality assured products, and because of the very high volumes that the Global Fund pushes through the WAMBO, the pool procurement platform, pricing is frequently the best, if not very optimized. However, in GC8, there is, as a part of next gen market shaping, there is a very significant focus and resourced here at the Secretariat to advance non-grant finance procurement, meaning procurements not financed through the grant, but through domestic dollars or otherwise. There's careful work that's happening. The board has both approved and advocated for this work so that pool procurement, the best pricing, quality assured drugs and commodities are made available outside of Global Fund grant resources. So more of that will come. And I hope that at least gives a decent enough answer. Back to you, Marcella.
Thanks, Julia. So if we go to the next slide, please, we're reading the next set of questions. Can you comment on the multi-country investments planned? Can you comment on the transitions that occurred under GC7 multi-country investments, and what is planned for transitions in GC8 for multi-country investments? What are the examples of human rights barriers in catalytic funding? The funding has been reduced, integrated approach is fine, but how will a country expand services with limited resources since the country is not in a position to support? The slide move, can we go back? Or is that the question? Yeah, sorry, okay. When will information notes initially published in December 2025 be republished on the website? Also, when can we expect the annexed templates to be available again on the website? Appreciate the engagement. My question is to understand how best we can engage when we're left out as key and vulnerable populations, mining communities, as we're not sure about the catalytic opportunities, and how do we access the allocation for Nigeria, especially the pool funding for NGOs? Matt, can I ask you to take on 15?
Marcella, I think 15 might need to be Lily, because it's
Lily?
specifically around changes from our multi-country investments in GC7 to now. If I may ask Lily to come and
Thank you.
So we're largely maintaining the same multi-country priorities from GC7 to GC8. In GC7, we have 2 multi-country approaches focused on malaria. one on HIV innovation, and then a very small one on lab system strengthening. The first three that I mentioned will transition in an evolved way into GC8 and with reduced funding. For the labs component, that will be transitioned to a regional initiative through the strategic initiative. So maintaining the support, but just in a different format.
Okay, thank you, Lily. Anna, can I call you on 16?
Thank you. So for GC8, the catalytic investment addressing human rights and gender barriers to services is really about ensuring that services remain accessible, acceptable, and quality healthcare, and barriers such as stigma and discrimination, punitive legal and violence, environments of violence through approaches can be addressed and supported. And a real focus here in this on expanding access to quality and discrimination-free healthcare, improving health-related laws, regulations, and policies to enable access to HIV, TB, and malaria services, things like improving legal literacy and legal support related to health services, addressing gender discrimination and norms that pose a barrier to HIV, TB, and malaria services, preventing and responding to violence against women and girls, sexual health education for adolescent girls and young women, and adolescent boys and young men, and social protection for adolescent girls and young women in high HIV incidence settings. So there's some of the approaches that will continue through the catalytic investment and mirroring and supporting what's in allocations as well. I think there's a couple on this slide I can answer while I have the mic. So also on the question related to 19, appreciate the engagement to understand how we can engage when we are left out as key and vulnerable populations and mining communities. So as part of the GC8 funding request process, again, coordinated through your country CCMs, communities are expected to participate meaningfully in the development of the funding request. The community annex, again, as mentioned before, is mandatory for high impact and core portfolios. This is a space. The Global Fund has a small amount of resources also available to support engagement at country level through our community engagement strategic initiative. So that's an option that can help ensure that participation, but also a variety of technical partners can support key population and vulnerable community groups to engage in this process in countries that partners such as Expertise France, UNAIDS can also support this work at country level. I don't know if you wanted me to also look at 17 or someone else's.
No. 17.
I have 17 and 18 for Julia.
Yeah. Okay, thank you. So it's true with reduced funding, we cannot look at integration as the answer to all things. It might be in part that. One of the important grant cycle 8 shifts is rigorous prioritization, programmatic prioritization, and reduction of program management costs. There are things that countries will have to determine as a collective through the country dialogue and beyond. They want to prioritize and deprioritize and stop financing. And that should be based on science, on the epidemiology of the country and the subnational epidemiology as appropriate, as well as the most impactful interventions. Integration is an important way to both potentially, in some cases, not always, improve the client experience and the health outcome, and can be more efficient. But the rigorous prioritization of programs and program interventions needs to be front and center in the country dialogue. On question 18 on the information notes and the templates, yes, they were initially published in 2025, and the Secretariat decided to take a very hard look at the very difficult situations that countries will be facing in terms of reduced funding allocations, total available funds, and how we can provide documents, small g guidance documents, and helpful notes to help in the country dialogue and prioritization discussions based on the GC8 shifts. So we took down the guidance on the website in order to align it with the GC8 shifts and to simplify it and make it very user-friendly. We're putting ourselves through the same rigorous process as we're asking you to in the country dialogue as well. So those will come up very shortly. I can only tell you just enormous amounts of work are going into this so that they're useful for you in your discussions. Thank you.
Thank you, Julia. Lindsay, if I can call you on 20.
Sure. So the question is about accessing the allocation, and specifically in this context, the question is about Nigeria, with then a second part of the question, which is about accessing pool funding for NGOs. So I just want to clarify that an allocation communication has gone out to the CCMs, the country coordinating mechanisms, as the primary applicant for each country that is receiving an allocation from the Global Fund. It is that CCM that is the body that is responsible for then having an integrated country dialogue and preparing the funding request application to then submit to the Global Fund to officially then request the funding that has been designated for that country. So that allocation access for Nigeria needs to be coordinated by the CCM who will develop the funding request for Nigeria. Now, there isn't set aside funding specifically for NGOs per se, but in most of our countries, we do have both government as well as civil society organization recipients of funding, whether or not they are principal recipients or sub-recipients. So if there is an interested NGO that is going to volunteer to be part of the overall implementation arrangements, they should be getting in touch with the CCM to understand the status of the funding request development and start engaging in some of the country dialogue.
Right, thank you, Lindsay. So if we can go to the next slide. Okay, thank you for all the clear presentations. Under the Next Gen Market Shaping and Response Funding, what are the amounts allocated for each disease area, HIV, TB, and malaria, and what are the priority products for this funding? Can you please comment on the Global Fund centrally managed limited investment funds, what remains under GC7 and how we're transitioning for GC8 and considered under these modalities that we're discussing, and have all the multi-country allocation letters have been sent out already? Are there newly established local CSOs eligible to apply for GC8? And could you confirm the country list of countries transitioning in GC8 and then also those countries transitioning in GC9? So for 22 and 23, Julia, can I leave those with you?
Do you want me to
If you can unmute, yes, thank you.
So on the first question about the Next Gen Market Shaping SI, there aren't predefined amounts for each disease area, and that's because the SI needs to respond agilely to the products in the pipeline and the opportunities as they emerge. So we've seen that really clearly in GC7. The SI has provided support across all 3 diseases to procure next generation nets, NPOC, and also LEN. So they've really capitalized as opportunities to come up to make sure that across the diseases, we're bringing those products online as quickly as possible. I'll hand over to Julia for 23.
23 is an excellent question, because I think the CLMI under C19 RM, the mechanism there for funding for C19 is an important one. Those funds are related to C19, not to GC7. They will be utilized throughout this year, and most of them deal with system support and providing technical assistance. Each of them is lodged, whether it be something like Boxer, which is really about supply chain management, has a natural home in GC8 in system strengthening. And we have benefited from having considerable private sector funds during the 8th replenishment come in specifically for cell system strengthening. And it is allowing a positive look at how we can continue to see countries move the work, whether it be in surveillance or in supply chain management forward. That does not mean that the CLM funding, as they were, will be continued as they started, because those were initiatives very specifically designed to accelerate the use of the C19 dollars, which were time limited and different than GC7. I hope I have not complicated things, but we're aware of the importance and how we need to facilitate that transition. Thank you.
Thanks, Julia. So the next question on the multi-country allocation letters, Lindsay, would you want to come in, or you want us to respond?
I can do that. The answer to this question is, I'll give you two pieces of the answer. The first piece is that there are two different sources of funding for multi-countries. There are some multi-country applications that are made up of allocation amounts for individual countries that have been grouped together. The allocation letters for those multi-countries, and there are 5 of them, those have been sent out. There is an additional source of funding for some multi-countries that are part of the Catalytic priority areas. And I think Lily already mentioned this. Those have not been fully operationalized yet. So the Catalytic multi-country funding communication has not been finalized yet. I think I'm also supposed to answer question 25.
25, that's your
right.
thanks.
Which is a question that says, are newly established local civil society organizations eligible to apply for Grant Cycle 8 funding? And again, I will take you back to the idea that is the CCM, the country coordinating mechanism that is responsible for applying to funding for the Global Fund. And it is the CCM that nominates the principal recipients and then provides the information about all of the implementation arrangements that include whether or not there are subrecipients, et cetera, that will be receiving funding underneath of the principal recipients in the overall approach for the country management of the Global Fund grants. Now, a new civil society organization might indeed be a helpful part of the overall implementation arrangements, but that would be up to the country key actors to decide.
Thank you, Lindsay. And for 26, Matt, can I call you back on the list of countries transition?
Yeah, absolutely. So as I've mentioned, we've communicated all of the lists directly to countries. We have not yet published the full list, and so I can't share it here now. But historically, the Global Fund has published a list of transition projections on our website ever since we've had the STC policy. And we are working right now on finalizing how we will share the overall list on GC8 and GC9 timeline countries externally.
Thanks, Matt. You can go to the next slide, Alex. Thank you. So how is the end of the USG President's Malaria Initiative, PMI, key country funding for malaria diagnostics and treatment considered in the country allocations? Are there any restrictions to allocating specific resources into key populations-friendly services, both community and facility-based, or is it now limited to key populations integrated services within PHC? Is size estimation based on BBS enough to justify including these activities into the grant proposals? When will the information notes be available? Regarding RSSH disease split decisions by CCMs, is there a guidance on target percentages, minimum, maximum that can be taken from individual disease components, or minimum, maximum allocations for RSSH as a whole within country splits? What are the concrete examples of expanding social contracting? Are we using Global Fund grants to facilitate contracting between government and civil societies as subrecipients and sub-subrecipients? Then will domestic co-financing be expecting gradually to replace such grants to civil society? So for 27, Yoon, please.
Yes. So yeah, thank you for that question. So before we run the allocation formula, we obtain the latest information from other donors, including USG, of what the likely funding will be for the next 3 years. And we get that data from them directly. That data is then put into the formula. And as Gideon had explained earlier, the formula will try to account for that by taking into account what the total funding is, looking at Global Fund and other external together. So it will account for cases where there's a really significant drop in funding in total and try to incrementally shift more funds to countries that are really affected. Then in the qualitative adjustment process, that's where we take a more granular look at other external financing and country by country. So there we would look at, for example, the activities that other donors such as PMI used to be funding and would no longer be continuing compared to what the Global Fund grants were funding. And this is also, looked at sort of comprehensively with other factors about that country, including what are the key coverage gaps in life-saving services, commodity costs of, malaria diagnostics and treatment, and taking all of that information together. That's where the qualitative adjustments panel would then, recommend an incremental increase potentially for that country based on that information. So it's really both considered in the formula and in the qualitative adjustments. But I will say, of course, the allocations are made at a certain point in time, and we can only really use the best available information that was, that was there then.
Thank you, Yun. So Anna, are you taking 28?
Yes. So the short answer for question 28 is there are no restrictions. So Global Fund financing and funding can be used for KP program delivery within facilities and community-based led service delivery models. Population size estimates and IBBS are always a good place to start to demonstrate the size and need and plan appropriately. However, data is not a prerequisite for service delivery, and it should not hold back KP programming where there is a need. Exploring how to integrate KP services into PHC where appropriate may be helpful, but also where you've had differentiated service delivery models, including community models, can still be funded from the Global Fund. Do you want me to also take 31 while I'm here?
Yes, please.
Yes. So for the social contracting, yes, outside of matching funds, grants should be able to use to facilitate social contracting, including ensuring mechanisms are in place for the procurement of services from community-led organizations or community-based organizations, both through direct government procurement, as well as by including community services in insurance schemes where relevant or such schemes exist. This includes ensuring that community-led organizations have the capacity to deliver on those contracts, and social contracting does not need to be introduced at national scale. Local or regional pilots are meaningful and relevant and can provide useful testing ground for the scale up or expansion. This can also include adding and gradually expanding service packages that can be funded through social contracting for community delivery. For example, community testing linkage, retention support, peer navigation, TB contact tracing, and gender responsive services. And whether domestic financing is expected to fully replace grants, it is country specific depending on the context and feasibility. And it's not just in terms of fiscal space, but also the political and legal context. However, the government is expected to play an increasing role in sustainably funding these critical community services that the grants have been funding.
Okay, thanks, Anna. Lindsay, can you respond to 30 on the disease split?
Sure, I can give a bit of information on this, and then Julia might want to complement with some more of a strategic perspective. But from a concrete response to the RSSH disease split process as part of the overall program split discussion in the CCM, there is no specific percentage that is suggested or required overall. This is an important consideration that each CCM needs to make, how they look at their overall program split from the indicative amount that the Global Fund has communicated to them in the allocation letter. Certainly for the high impact and core portfolios, we expect that the CCM also then discusses how much from each of the HIV, TB, malaria allocation would be designated to RSSH and to document that in the program split confirmation form. So that is a requirement for the high impact and core portfolios to have that discussion, to document it. But the Global Fund is not prescribing the exact amount that is expected. We generally would say, though, that it is appropriate for each of those disease components to contribute an equal amount. Julia, did you want to add anything to that?
I do not. That was complete. Thank you so much. And 29, we've responded to already.
That's right. Okay, we move to the next slide. So for some countries, the split for HIV and TB are lower compared to GC7 while malaria is maintained. What's the rationale? So is that the Global Fund can have attestations of donations for SRs and SSRs to exempt them of taxes. And then in the strategic shifts presentation, the disease component closures were discussed for GC8 and GC9. Where can we access information on the full list of countries disease components impacted, and what does this mean for GC10, etc.? 20% of co-financing is calculated as 20% of the allocated fund. And can you compare GC7 against GC8 funding allocation totals? Gideon, would you take 32?
Yes. So without speaking to any specific countries, I think the first thing to note here is that the global disease split that we mentioned earlier is a portfolio level split, and that it does not define the split at the country level. So the split between the diseases in the allocation letters at the country level is defined by the relative disease burden of each of the 3 diseases within the country. The global disease split is not applied for all the countries in that sense. There may indeed be countries, as the question suggests, where the HIV and TB components of the allocation are lower than in previous cycles, while the malaria allocation remains the same. Such an outcome would likely be driven by a high malaria burden and a relatively lower burden of HIV and tuberculosis within that country. The formula in that situation is continuing to protect the highest burden malaria component.
Okay, thank you, Gideon. Natasha, do you want to come in? If you can.
Can you hear me, Marcella?
Yes, we can hear you. Thanks.
Fantastic. So as a matter of principle, all principal recipients, i.e. those entities who sign grants with us, must ensure that all services and procurements made with grant funds are tax exempt. So the SRs and the SSRs, i.e. the subrecipients and the sub-subrecipients, must coordinate with the PRs to ensure that those services are tax exempt. This is not a responsibility as such for the Global Fund. Thanks so much.
Thanks, Natasha. Matt, would you want to take 34?
Yes, I should probably take 34, 35. Is that okay, Marcella?
Yes, please.
So I think 34 I've already addressed, but just to be clear, in the strategic shifts presentation, what was discussed was that we're setting transition timelines for a subset of the portfolio for GC8 and GC9. And again, that's really to strengthen predictability in our financing and work closely with countries to support as effective a transition as possible. And As I mentioned, we're working on how we will publish that information externally, but it has been communicated directly to countries. On the part of the question around GC10, we did not set transition timelines for a lot of the portfolio, including for GC10. But we are working really hard to make sure that we work closely with countries now to co-create transition pathways, even if a timeline is not set. And what we mean by that is that we know that that supporting the transition process takes time. We know it often takes changes in the way that our grants are designed, transformations at the national level, improvements in domestic financing, strong co-financing commitments, institutionalization of the relationships between civil society and community systems and governments. There's so many things that we need to do. And so recognizing the uncertainty that we're operating under and the shifts in financing, we really want all countries to make this a part of their thinking for GC8, even where there isn't a transition timeline. And that's a really critical part of that strategic shift. So I hope that helps with number 34. On number 35, the co-financing amounts. So the question is about how do we calculate the amount of the co-financing requirements? The co-financing requirements or amounts are calculated fundamentally on two things: the amount of the allocation and the requirements that are board approved in the SDC policy. So for low-income countries, the minimum standard amount in the SDC policy is 7.5% of the allocation. So that means if a country has a $100 million allocation, the minimum standard amount of additional funding we want for co-financing is $7.5 million. That can change, and in some places, the Secretariat has the flexibility to increase that amount, and in some places we have. In some places we've in line with our strategic goals, increased that amount, but it's set based on the allocation. And in lower middle income countries or middle income countries, that amount is larger. As a standard, it's 15% of the allocation and also can be adjusted. So in summary, the amount is set based on the board approved requirements in the SDC policy, our sustainability transition and co-financing policy, and the size of the allocation.
Thanks, Matt. So the last question on this slide is 36. Yun, would you like to come in for this one?
That question, thanks, Marcella. I mean, this is, I guess, somewhat, en fait, premièrement, juste merci beaucoup.
So 37.
Oh, yes. Oh, I'm so sorry.
Sorry, are you asking for 36 or 37?
36. She has 36, 37, but we only have 36 on this
I skipped over, sorry.
Sure. So on question 36, a great question on whether we can compare the totals for GC7 and GC8. The most important thing to bear in mind here is that during 2025, we went through a very significant reprioritization process, and therefore a direct comparison of the allocation letter numbers in Grant Cycle 7 and allocation letter numbers in Grant Cycle 8 is not comparing like for like. The actual funding in GC7 was lower in the end after the reprioritization than the initial allocation letter amount. We've provided in the slides, as you've seen, comparisons that include the original Grant Cycle 7 amount, the reduced reprioritized Grant Cycle 7 amount, and the Grant Cycle 8 amount across a variety of groupings: disease, income group, and region. And if you're making these high-level comparisons, these funding allocation total comparisons between them, we'd advise to use those. These slides will be available, speaking under Marcella's control, in the next few days after this session.
Thanks, Gideon. So if we can go to the next slide, just to share with participants that we have lots of questions. We will not be able to respond to all of them today, but we're taking your questions, and if we're going to put an email in the chat. So if we haven't responded to your questions, please send us a message or contact your country teams, and we will respond directly. So I'm going to go to a slide 37. Donc, je vais le faire en français, comme ça c'est plus facile pour les lire. Donc, plusieurs pays, dont des pays africains, ont signé avec le département d'État américain des conventions sanitaires qui couvrent la lutte contre le VIH, la tuberculose et le paludisme pour une période de 5 ans. Les financements ainsi obtenus par pays seront-ils pris en compte lors des allocations? Si oui, quelle sera la méthodologie?
The affirmations of the responses as regard the methodologies and alignments between the different interventions. Otherwise, how can we take into account the risks as regard the duplications of intervention in an atmosphere where we don't have resources?
Across TB and HIV, including cross-trained paralegals, given that build community networks and engagement to enable access to services is a GC8 catalytic investment priority. Can we integrate community-led monitoring to be positioned under this priority, or is it only accessible through the multi-country modality? How should cross-disease country-led monitoring be framed in the funding request under RSSH, TB, HIV, or both? How do we get access to the CCM focal person for Nigeria? And I would like to know if there will be any training for CCMs on proposal submission. And now 37 is you.
Thank you, Marcella. And first of all, just apologies that I'll be responding to this in English. Excusez-moi, just because I think I've learned all my global fund vocabulary in English. So this is very much related, I think, to the other USG external financing question earlier. And, you know, as I said, like at the time of the allocations, we did use the best available information from USG to determine those allocation amounts. But with those allocation amounts, how should interventions be prioritized? That's really up to, I think, the country dialogue and funding request process with in-country stakeholders, with partners, with communities, to determine what's the best way to prioritize activities within those funds in light of the USG MOUs that countries have signed. And we would absolutely encourage countries to use the latest available information on that to ensure that as those funding requests come to the Global Fund, to avoid that duplication and make sure that we're actually maximizing the impact of recent investments across all sources and not just from the Global Fund.
Okay, thank you. Anna, would you like to come on the next on 38?
Thank you. For community-led monitoring, the country grant allocations remain the primary vehicle for including the costs for implementation. And this includes priorities for integrating community-led monitoring. You'll find these in the modular framework with an emphasis on ensuring that community-led monitoring is positioned as a quality assurance mechanism and working towards integrating into national or subnational health quality improvement mechanisms, or also around domestic financing and continuing the good work in advocacy that has been done to date. This also includes integrated community-led monitoring approaches where it makes sense, both integration across diseases, including the example that you've provided there for HIV and TB, as well as non-disease programs related to access or quality of health services, for example, human rights. Community-led monitoring is included under the RSSH modules, under the community system strengthening interventions, and they're best included there. There will be some additional support through catalytic investments yet to be defined, where we're looking at new and innovative roles for community-led monitoring in terms of sustainability and social contracting.
Okay, so question 39 has been responded in the chat by Lindsay. Lindsay, if you want to talk about 40.
I will. I'll just mention question 39 was about how to get in touch with a focal point on your CCM. And I've put that into the chat, the link that you can go to, and then you search the country and look in the overview tab to then get the contact details for a focal point for the CCM in your specific country that you're interested in. Question 40 is about whether there is any training for CCMs on proposal submission. There has been training already. We've been doing information sessions on how to apply using the full review application, for example, for the high impact core portfolios. The recording of that session, along with those slides, is available on the Global Fund website in that information session link. We are additionally providing a final information session for focused portfolios this coming Friday. So if you are in a focused portfolio, that training would be relevant for you, and we'll be going through the expectations and how to complete the form and the required annexes. So you can register for that information session for this coming Friday if you're a focused country. Finally, there will be new information sessions that will be coming up in the month of April to support CCMs and other applicants on how to actually submit their funding application on the partner portal. That is a new step for Grant Cycle 8, and so we will be conducting additional support trainings for CCMs in the month of April.
Okay, thank you, Lindsay. We're at time. What we will do is, for the rest of the questions that haven't been responded, we are going to respond them in writing and send them to the participants who registered. So if your question hasn't been answered, we also added an email address in the chat. You can take that email address and send us your questions, and we will respond. We have a short survey to see if you appreciated the session, so we ask you for a couple of minutes to respond. We would like to thank all of you for coming today and for your participation and engagement. Thanks the presenters as well, and thank you so much to the interpreters. And have a good afternoon, everyone. Thank you.